Morning. I'm at HRS on day 3 with my great friend and colleague Prash Sanders from the Royal Adelaide Hospital. Welcome, Prash.
Thanks, Pete.
Prash has really been at the forefront of research into risk factor modification, starting with his work on obesity. And throughout the meeting and throughout all the recent literature, we hear about the importance of risk factor modification. And I thought this would be a great opportunity for you to tell us a little bit more about how we can deliver this to our patients.
Yeah, so this is, we now know that risk factor modification improves the outcomes in terms of AF care, both in terms of recurrence of AF, in terms of ablation outcomes, and how patients feel. So it's an important factor, and it's named as the first pillar of AF management now in the American Heart Guidelines. So how do we deliver this? It's really by getting to know the person and making small changes at a time in order to sustain long-term changes. So what do I mean by this? So if you have someone who needs to lose 20 kilograms of weight, we're talking about giving them a target of 1 to 2 kilograms over a 3-month period, something that they can achieve, be motivated by achieving it, and then go on to the eventual target. You've got to make small changes to get behavioral change in the long term, to sustain this kind of thing. And we do this for each risk factor that the person has, because AF is obviously a multi-risk factor condition, and unless we treat each of these risk factors, we're going to find that it comes back from causing by one of the others.
And whose role do you think it is to deliver risk factor modification?
So what is becoming apparent is actually you just need a steady person. A person who has a relationship with the person, with the a patient, who gets to know them, knows their motivations, knows the things that hurdles that they have in their lifestyle, so that you can then work with them to come up with joint decisions on how you're going to modify that. It doesn't seem to matter whether it's an EP fellow, an EP attending, a nurse practitioner, a pharmacist. You know, we've managed to do that with each of those. There is a misconception that you actually need everyone in the same room, but actually that's not the case. You need one person working with the individual. You may need to refer people appropriately. For example, sleep apnea. You may need to refer to a sleep service, but you don't need them in the room. Similarly for the endocrinologist for diabetes management. There may be some patients who need to go onto that, but it's not everyone. Keep it simple.
Okay. Do you think there's a hierarchy of risk factors when you're confronted with someone with a full hand, if you like?
Yeah, I think it's important to assess each risk. Each person's different, so the hierarchy is going to be different for each person, and you will find that often there's one that's more dominant, whether it's, as you've shown, alcohol being a very dominant risk factor, or whether it's actually obesity, and often they go hand in hand, and unless you treat the alcohol, you're not going to get their weight down. So it is important to identify what they're using as their dominant risk factor for their cause of AF. And that's probably the first one to target, and it become apparent as you ask them questions about each of those risk factors.
We heard earlier in the late breakers about one of the newer obesity drugs and its potential impact on AF. What's your impression of those?
So I think, you know, the impact weight has on bad outcomes for AF is so high that really doesn't matter what route you use to get the weight loss down. The key is to get the weight loss down. Now, having said that, there are some nuances between each of these. So, for example, intermittent fasting has a greater risk of inflammation, which could be more harmful than if you made gradual dietary restrictions. So we don't know what these new drugs are going to have as additive effects or side effects profile in terms of long-term use, and so we do need to reserve it for the appropriate person, and then still continue to make those small changes so that you can sustain it in the long term and get them off the drug eventually.
Congratulations on your recent paper with Adrian Elliott on the role of exercise. What are some of the practical ways we can get our patients moving?
So Active AF was an important study because it looked at really just exercise and a exercise physiologist guided exercise program to increase exercise levels, aerobic exercise, up to 210 minutes per week. This is higher than what's been previously recommended and clearly showed a difference in hard outcome of AF recurrence and also in terms of symptoms. At an individual patient level, give them small targets to achieve. So if your patient is sedentary, you're going to ask them to walk for 5 minutes a day. As you move on that road, you can increase that gradually up, knowing your target is 210 minutes per week and increasing aerobic levels. But if you ask them to do it straight away, you may actually lose them. So you do it in small increments in order to achieve the final goal.
Do you think wearables are helpful in getting people active? Have you seen a role for them?
Yeah, it depends on the personality of the individual. It comes down to getting to know your patient. If that's someone who's going to be motivated by having feedback mechanisms, then that's going to be a great tool. But there's some who will turn off from it, so get to know your patient first.
All right, terrific. Thanks very much for your time this morning, Prash.
Thanks, Pete.
It's been a pleasure.